Good afternoon, and welcome to today's webinar brought to you by the Center for Migration Studies, a think tank and educational institute devoted to the study of international migration, to the promotion of understanding between immigrants and receiving communities, and to public policies that safeguard the dignity and rights of migrants, refugees, and newcomers. My name is Matt Lysecki, CMS's Senior Research and Policy Analyst. Today, we will focus on a new report from CMS titled Essential But Ignored, Low-Earning Immigrant Healthcare Workers and Their Role in the Health of New York City. In this report, written by myself and my colleague, CMS Senior Fellow Vicki Virgin, we examine the significant contributions to the city's healthcare workforce made by immigrant workers, with a focus on the large share of immigrant healthcare workers with unsustainably low earnings. In today's webinar, Vicki and I will present the report's findings and policy recommendations. We'll then hear reflections on the report from two distinguished discussants with deep experience on the city's healthcare workforce. First, we'll hear from Max Hadler, Senior Director of Policy and Immigrant Initiatives at the New York City Department of Health and Mental Hygiene, followed by comments from Barbara Caress, Adjunct Assistant Professor at the Marks School of Public and International Affairs at Baruch College. A few logistical notes before we begin. The presentations and discussion will cover roughly 45 minutes. With the remaining time, we'll take questions from the audience. If you have a question at any point during the webinar, please feel free to enter it via the Q&A feature. This webinar is being recorded, and following the event, we will post the recording to the CMS website. Also, before I begin, I would like to acknowledge the generous support of the Mother Cabrini Health Foundation, whose partnership and dedication to advancing the health and well-being of all across New York State made this project possible. So with that, I'll go ahead and get started. The initial motivation for this project came from the city's response to the COVID pandemic, during which our healthcare workers were at the front lines, risking their physical and mental health in order to see us safely through the worst of the crisis. This workforce included physicians, surgeons, and registered nurses, as well as nursing assistants, medical assistants, home care workers, and others in support roles vital to keeping the whole system functioning. These roles are often low paid and commonly staffed by immigrant workers. With the acute crisis of COVID receding, we wanted to understand the working and living conditions of the sector of the workforce to whom we owe so much. With the current political climate around immigration, we also sought to understand the importance of foreign-born workers in maintaining and growing our healthcare system's capacity. Using our research findings, we also prepared a set of recommendations for politicians, city and state governmental agencies, and advocacy organizations to refer to as they work to meaningfully improve conditions for these essential workers. So to give a sense of scale, the total workforce in New York City is a little over 4.3 million workers. Of those, 520,100 workers are in healthcare occupations. And we'll go into a little more detail on those occupations shortly. We split that population by two different distinctions in our analysis, looking both at earnings, where we find that 322,000 workers, or 62% of the healthcare workforce, have earnings below our defined threshold of 2/3 of the city's mean annual income, as well as nativity, where we find that 295,200 workers, or 57% of the healthcare workforce, were born outside the United States. Together, these groups combine to make up 203,500 low-earning immigrant healthcare workers, or 39% of the city's total healthcare workforce. Our data for this report come primarily from the U.S. Census Bureau's American Community Survey, with supplemental data from the Federal Bureau of Labor Statistics. The Census Bureau splits healthcare occupations into two subcategories: healthcare support occupations and healthcare practitioner and technical occupations. As you can see from this table, both subgroups grew significantly from 2010 to 2022, with healthcare support occupations clocking in as the city's fastest growing subgroup over that time period. When we combine these groups, we see that the total healthcare workforce is the single largest occupational group in the city. One other item to note in this table are median earnings, where we see a significant split between healthcare subgroups. Practitioner and technical occupations have a mean annual income over $83,000, whereas those in support occupations report a median income less than 1/3 of that amount, at only $26,100 per year. This is also approximately half of the citywide median income for all workers, $52,100. For more on occupational roles, earnings, and other findings, I'll now hand it off to Vicki.
Hello, everyone, and welcome. Thank you, Matt. So as Matt just mentioned, that the Census Bureau divides the healthcare occupations into two subcategories. We can switch slides, Matt. Thank you. So on the right, we've got the practitioner and technical occupations, of which the largest groups are registered nurses, physicians, licensed practical and vocational nurses, and pharmacists. And support occupations are the second subcategory. The largest groups in this subcategory are home health and personal care aides, nursing assistants, medical and dental assistants. So you can see that the majority, 56% of all healthcare workers, work in the support occupations. This pie shows the top detailed occupations for all healthcare workers. By far, the largest occupation is home health and personal care aides. They number about 202,000 and they account for 39% of the total. Nursing assistants, this gray slice of the pie, this is an occupation that's closely identified with home health aides, and they're often analyzed together. So putting these two groups together, we combine them to get 46%. So close to half of all healthcare workers are employed in just these two occupations. Registered nurses are the second largest occupation. They account for 14% and they number about 71,000. And physicians, there are 34,000 and they comprise 7% of the total. This figure shows median hourly earnings for the largest occupations. So these occupations are rank ordered by the size of workers in each occupation. So the first bar, we have home health and personal care aides with the largest number of workers. They have also the lowest hourly earnings of all groups, just $16. This is barely above the minimum wage of $15 an hour in New York City in 2022. The next largest occupation, registered nurses, earn $46 an hour. Nursing assistants, $21 an hour. Physicians, $67, and so on. So the largest number of workers are also the ones with the lowest earnings, which skew the total earnings overall downward. Median earnings for all healthcare workers is $23 an hour, which is lower than the citywide average and also $5 below the living wage in New York, which is $28 an hour. In order to provide some kind of context for our analysis of healthcare workers, we next compare them with all other workers in the workforce. The big key takeaway from this chart is that healthcare workers are predominantly women, older, and more likely to be foreign-born. More than 3/4, 77%, are female compared to 46% for all other workers. 57% are foreign-born. That's 15 percentage points higher than for all other workers, and they are considerably older. You can see that in the 55 years and older, but I also want to give you median age, which isn't on this chart, but the median age for healthcare workers is 45 years, and for all other workers, it's 39 years. So it's a six full years older than all other workers, excuse me. Other notes of interest on this slide are the share that have at least one child in the home, 48% of healthcare workers compared to 36% for all other workers, and they are more likely to be part-time workers. Next, I wanted to show these two pies for foreign-born workers by immigration legal status. Again, comparing healthcare workers with all other workers. So in the left pie, you can see that healthcare workers are much more likely to be naturalized citizens. 2/3, 65%, compared to 57% for all other immigrant workers. Also of interest on this slide is the underrepresentation of undocumented immigrants in the healthcare occupations. Just 9% of immigrant healthcare workers are undocumented, compared to almost double that share for all other workers, 16%. The next chart shows the important role that immigrants play in many occupations, but in particular the healthcare occupations. These occupational subgroups are rank ordered by the share of foreign-born workers. So the first bar, healthcare support workers, have the largest share foreign-born, 67%, the highest of all groups. Close behind, however, are workers in the cleaning and maintenance, and also workers in construction occupations. The last bar on this chart, healthcare practitioner and technical, 43% of their share is foreign-born. It's smaller than the other groups. However, it is still significant. This means that a large share of doctors, nurses, and other skilled healthcare workers are immigrants. Next, we look to see if citizenship makes a difference. In other words, how do immigrants fare compared to those who are native-born? And we find that immigrant healthcare workers are even more likely to be female and older. 81% of foreign-born healthcare workers are women, compared to just 72% of native-born. They are also much more likely to have at least one child under 18 in the home, more than half, 56% compared to 37%. This could indicate greater household responsibilities for foreign-born workers. Immigrants are also much more likely to live in overcrowded households. 1 in 5 live in these conditions, twice the share for native-born workers, 11%. Next, we turn to low-earning workers. So for this study, we define low earnings to be 2/3 of the average wage for full-time year-round workers. For New York City in 2022, this comes to $29.67 to be precise. This is roughly the living wage that I mentioned earlier to be $28. So this is in the ballpark of, how we define low earnings is in the ballpark of what we consider also to be the living wage. Overall, 62% of healthcare workers are defined as low earners. There is a significant difference, however, between native and foreign-born workers. 69% of foreign-born workers are low earners, compared to just over half, 53% for native-born, a 16 percentage point difference. Of the foreign-born group, naturalized citizens have the smallest share, 62% of their workers defined as low earners. And then, as immigration legal status becomes more precarious, the share increases. 84% of all undocumented immigrants, 84% of all undocumented healthcare workers have low wages. From here on, we're going to focus on that foreign-born bar of the last slide, low-earning immigrant workers. There are about 204,000 in this population. This is a pie of detailed occupations for this group. And we see that home health and personal care aides comprise an overwhelming majority, 66%. And nursing assistants, the second largest group, comprise 11%. So combining these two occupations, these groups together account for close to 80% of this population. So this is yet more evidence that supports a key finding in our report, that there are a large number of home health and personal care aides who are struggling. Next slide. This next chart shows the top sending countries for low earning immigrants. The Dominican Republic and China are the top two. They are also the largest immigrant groups in the city, so this makes sense. However, note the dominance of West Indian countries. Jamaica, the third, followed by Guyana in fourth place. When you combine these with the other two West Indian countries of Haiti and Trinidad and Tobago, you get 21%. So 1 in 5 of immigrant healthcare workers with low earnings come from these 4 West Indian countries. Also of interest on this list is the presence of Ghana in the 5th place and Bangladesh. Immigrants from these 2 countries are both relatively newcomers to the city. Another important finding from this slide is the absence of Mexico. Immigrants from Mexico are the 3rd largest immigrant group in the city, so not even making this top 10 list is noteworthy. And last, we take a look at the borough of residence. The pie on the right is the borough distribution of all immigrants in the city, and the pie on the left is for the low-earning immigrant healthcare workers. The key takeaway from this slide is that low-earning healthcare immigrants are more likely to live in the Bronx relative to Queens. Of all low-earning immigrant workers, 25% live in the Bronx, compared to their overall share of just 16% in the total foreign-born population. Queens has the largest share of immigrants, 36%, but only 28% of the low-earning immigrant healthcare workers live in this borough. This makes sense because the Bronx is a poorer borough than the Queens, but it is still important to call out because Queens, the borough of immigrants, usually gets the attention, as it should. However, CBOs, city agencies, and other groups who provide support for immigrants should keep in mind that even though the Bronx has a smaller immigrant population, they are home to a disproportionate share of those with low earnings. And with that, I turn it back to you, Matt, for policy recommendations. Thank you.
Thanks, Vicki. So to summarize what we've discussed so far, healthcare workers are the city's largest occupational group, and over half of the city's healthcare workers are immigrants. Over 2/3 of immigrant healthcare workers are low earners, and over 3/4 are women. These workers are more likely to be 55 and older, more likely to live in overcrowded housing, have at least one child in the home, and access health insurance through Medicaid. To maintain the healthcare system's current level of capacity, we rely on a majority immigrant workforce. According to the federal and state bureaus of labor statistics, the need for healthcare workers, especially home health and personal care aides, is expected to rise significantly as the population ages over the next decade. We need more healthcare workers, and we cannot afford to lose those we currently have, not through low wages for healthcare work, not through the lack of affordable public services, and not through decreasing employment rates for immigrant workers due to either enforcement actions or the chilling effect of fear. We combine this need with the moral imperative to support and care for those who support and care for us. To do so, we need to enact policies designed to attract and retain workers at all levels of the healthcare system. To do so, we recommend the following. First, increase wages for healthcare support occupations. Adjusted for inflation, home healthcare service workers lost 9% of wages from 2019 to 2023, according to researchers at the New School. There are efforts to raise wages at the state level, such as the Fair Pay for Home Care campaign, which includes legislation to guarantee home care workers' wages at 150% of the applicable minimum wage. Other mechanisms for wage growth include the prevailing wage approach of establishing citywide benchmarks for wages and then requiring those benchmarks of all employers funded by city contracts. Despite a significant upfront investment, the estimated net benefit, that's the benefit over the amount it costs, from increased healthcare wages is high, as researchers from the City University of New York project an additional $3.7 to $6.6 billion per year, billion with a B, added to the city's economy. Next, we recommend enforcing current labor laws for healthcare employers. The state attorney general recently prosecuted cases against 2 major home care agencies for failure to comply with the Wage Parity Act, which resulted in millions of dollars in settlements paid to the state Medicaid fund and to impacted employees. In addition to the Wage Parity Act, the state Domestic Workers Bill of Rights requires paid rest days, and the New York City Paid Safe and Sick Leave law requires at least 40 hours of paid time off for health and safety reasons. Advocates can support healthcare workers by continuing to provide educational resources, including training on the process of filing labor violation complaints. Next, we recommend addressing the benefits cliff. So our current system forces part-time workers to forego working additional hours that would put their income over the thresholds needed to access public benefits, causing people to face the difficult choice between needed income and access to benefits such as Medicaid or SNAP. As we saw above, 36% of immigrant healthcare workers work part-time. Solutions to this include indexing benefits to financial stability standards, such as the living wage, or gradually phasing out benefits to avoid their complete loss the moment a threshold is crossed. We also recommend promoting worker-owned cooperatives for healthcare support roles. The benefits of co-ops are high for industries with limited worker protections as they foster community and promote workers pooling resources. Co-ops also open doors to employment and benefits for all, regardless of immigration status. The next four of our recommendations apply to those beyond the healthcare workforce, though our findings suggest they would be particularly beneficial to immigrant healthcare workers. One such recommendation is to expand access to affordable childcare. As we saw above, over half of low-earning immigrant healthcare workers are raising children, and many are doing so without the support of a spouse. The New York City Campaign for Children is working to make childcare more affordable, accessible, and equitable. At the state level, the Child Care Assistance Program, or CCAP, began in July 2024, covering some childcare expenses for workers earning below 85% of the state median income. One item to note, CCAP information is only available in English and Spanish, and we encourage the Office of Family and Children Services to provide program information in a wider range of languages, reflecting the diversity of New York's immigrant communities. Next, we need to increase access to affordable housing. Recent developments on this front include the City Council banning landlords from passing broker fees on to tenants, the city's Department of Housing Preservation and Development passing tax incentives for affordable housing, and a new pilot program allowing legal conversion of basement apartments to increase the city's stock of safe, regulated housing. Next, we recommend advocating for resources to support ESOL classes. This is important for accessing the full range of information vital to workers, including explanation of benefits, materials notifying workers of their rights, and mechanisms for reporting abuses of those rights. And finally, we recommend expanding Medicaid eligibility regardless of immigration status. New York State recently expanded Medicaid coverage for all those age 65 and older. States such as California have recently expanded Medicaid coverage to all regardless of age, and we encourage lawmakers in New York to do so as well. So with that, I'll now hand things over to Max Hadler of the Department of Health for his comments.
Great, thanks, Matt. Thanks, Vicky. Thank you to Mario and CMS for having me here. I'm joining from my phone, but hopefully everything is okay. Hearing-wise, I've had some tech troubles in the last half an hour or so, but really happy to be here and to respond a bit to this great report that Matt and Vicky just presented. So I work at the New York City Department of Health and Mental Hygiene in an office called the Office of Healthcare Access and Policy. And so we work on healthcare access and coverage issues that affect low-income New Yorkers with a particular focus on immigrant communities. And we analyze the impact of policy at all levels of government. So certainly what's happening at the city level, but also the ways in which state and federal policy impacts healthcare access for these populations and the programs and people who support access to those programs like Medicaid, the Essential Plan, NYC Care, funding mechanisms for safety net providers, worker-centered initiatives. So a lot of ways that our work overlaps with the content presented in this report. And I really commend CMS on the value of these data in helping to inform programming and policymaking. And as a policy person, I particularly appreciate the emphasis on the needed policy changes that Matt presented at the end there. And I'm going to focus on that in a second. But I just want to note a few broader contextual points, that I see in this report and how it relates to the work that my team and my office do. One is that I think that the central role of immigrants as essential workers was fleetingly, but to some extent recognized during the COVID-19 pandemic. And I think it's really important to recognize their role in ongoing backbone sectors of an aging society ongoing. such as the home health industry. And I think this report provides an important contribution to that body of knowledge. I also want to acknowledge the timeliness of the report and its discussion both of the importance of immigrant communities in the healthcare workforce and also more generally about working low-income people who receive public benefits at a time when there's a major federal fight brewing over the status and structure of the Medicaid program. And I think this report's a great contribution to the literature as well on the complexities for working people in public benefits and how those life circumstances interact. I also think there's a broad tendency in allusions to this population to focus on the importance of immigrant workers for the benefit of society at large or for particular industries. And I commend you all for lifting up the complexities of decision-making for workers themselves and the community, workers as community members, how this relates to their lives, their livelihoods, and their considerations in terms of protections for them, like their own health insurance coverage. And then, I think this was alluded to at the top, but I just want to recognize and acknowledge the uncertainty that people in immigrant communities feel right now, as it relates to people potentially losing work authorization, losing access to certain types of benefits, losing confidence in their ability to remain in the US or to plan for their future. And note that those impacts and uncertainties are felt well beyond the healthcare workforce itself. Considering some of the data that were presented that healthcare workers highlighted in this report are more likely to be women. They are disproportionately likely to be the sole breadwinners for their families. So if we're talking about the livelihoods of individual workers, we should really have in mind that we're also talking about the carry-on impacts on families and on a much larger population than the already sizable population we're discussing, comprised of low-earning immigrant healthcare workers. Okay, so now I want to take a few minutes to talk about some of the policy recommendations and how I see them interacting with some of the work that we've been doing at the health department, and focusing in particular around the healthcare access issues that my team, I'm looking at recommendations around expanding of the series of issues under the benefits header. So in terms of coverage for all low-income people, that's something that we have been pretty outspoken about in the city for a while and continue to want to see a path forward for it. Immigrant New Yorkers are still twice as likely as US-born New Yorkers to be uninsured. And the reasons for that are multi-tiered, some of which the report gets into in more detail. I'm going to name two of them here. One is related to coverage eligibility requirements that discriminate based on immigration status. And another really important one is related to the sectors in which immigrant workers disproportionately operate and work. In terms of the eligibility requirements, Matt alluded to this. We've seen a lot of progress in other states. We've seen some progress in New York State, most recently granting eligibility for Medicaid to people who are 65 and over, regardless of immigration status. This adds to a longstanding policy in New York State of covering children until they turn 19, regardless of status. But clearly, there are huge gaps that remain, and we'd like to see these policies extended to cover more working age adults. And then in terms of employer-sponsored coverage, immigrants are more likely to be employed than US-born people overall, but they're employed in industries that are less likely to provide coverage, like to a large degree, the industries that we're talking about today. And we continue to exist in a largely insurance context that creates, really huge coverage gap. And I think the CMS report does well to explore the issues as they relate to workers. It's often not offered. They're working, they're working part-time, they're working multiple jobs part-time. None of that couples together equals employer-sponsored insurance in a lot of cases. And that leads to a lot of issues, one of which is this benefits cliff, multifaceted benefits cliff issue, for which I think there are, a range of possible solutions. I mean, there's wholesale changes like a single payer system, which would, remove the connection between income and coverage. So that's one possibility. There are other more incremental approaches, some of which the state in particular. And I should also acknowledge that, I work for the city and I keep talking about the state. This is in part because we focus a lot on health insurance coverage, and the state is the level of government that regulates most health insurance coverage that we're concerned with. So, we spend a lot of time focusing on access points and policies that affect people in the city, but a lot of the policy setting happens at the state and federal level. And so I do think that the state has done well with some components of the Medicaid cliff in terms of income. For example, by creating the essential plan, which is a plan for people, primarily for people who make a little bit too much for Medicaid. So they initially created a system for people who make up to 200% of the federal poverty level, as opposed to recently raised that limit up to 250%. So in New York State, the cliff that that a lot of people experience is potentially not quite as steep at the same income levels, because there is this additional program layered on top of Medicaid. And I think we've also had some interesting recent experience with the flexibilities that the federal government granted to states as the pandemic policies were unwinding, and there was a continuous coverage requirement that the federal government had during the pandemic, where they would increase their payments to states on the condition that states not disenroll anyone from Medicaid. So there was some interesting experiences in terms of seeing what would happen when people aren't forced to go through the renewals process, and administratively, that's a point at which many people wind up losing their coverage. And the federal government allowed states several different types of fairly technical flexibilities to help verify whether people remained eligible for coverage without requiring people to take any action based on existing data sources that the state had, for example. And I think those, New York State took advantage of a lot of those flexibilities. It was quite successful. And so thinking about some of those as options for simplifying or automating processes that do not kick people off of their coverage due to inaction. And then there's been a few other policies instituted, one related to children up until age 6 being continuously eligible for coverage, so not needing to do annual renewals, which is a new policy in the state. And then, there are other efforts around specific populations or programs. There's currently a bill in the state legislature about automatically renewing certain people who have managed long-term care plans. So that's an interesting one to look at. And then just a couple more points before I wrap up. I just want to lift up some of the city work around making people aware of benefits that they're eligible for. So this is not something that solves for the benefits cliff per se on a policy level as it relates to income, but just trying to ensure that as many people as possible are aware of benefits that might be available to them, through the city's Office of Health Insurance Services, through the Get Covered NYC initiative, through financial assistance mechanisms that exist at New York City Health and Hospitals, the Department of Social Services. But so that's a bit uplifting, big but. It's also really important, I think, to recognize that the current federal administration is, among many things, proposing changes that they themselves acknowledge will lead to people losing coverage for administrative reasons. So if folks haven't had a chance to look, the other CMS, the Centers for Medicare and Medicaid Services, has a proposed regulation that's open for public comment right now around changes that would cause changes not only at the federal level, but also force changes in the New York State marketplace that might be interesting for folks to look at, in addition to the bigger Medicaid fight context that I alluded to earlier. So I think that the uncertainty around a lot of these issues is quite significant right now, which I think also makes this conversation and this report all the more timely. So I will stop there and look forward to the conversation and pass it back to Matt. Thanks.
Thanks, Max. It's great to hear about the work that the city is doing to try to connect people to the benefits and rights they're eligible for, especially in the face of the federal administration pushing in the other direction. Next, I will hand things over to Barbara.
Thanks, Matt, again, and I second Max's compliments about the report. I too found it really well done, well documented, and thoughtful. So thank you. I want to actually add on to what Max was saying and talk about a very specific problem, and then maybe have a couple of more generic comments. The very specific problem I want to talk about is the threat to the health insurance coverage. Most home care workers work at this moment for one single fiscal intermediary called PPL, a company that was awarded a contract by the governor in September and was allegedly supposed to transition 260,000 clients and between 350,000 and 400,000 workers into a single paymaster. And that is a mess, and I can talk some about it. One of the side issues that has come to the fore and really not paid much attention to is that PPL, in its infinite wisdom, is offering health insurance coverage. It's unaffordable and it's terrible coverage. It's unaffordable because they're going to be charging workers $212 a month for single coverage and some huge number for family coverage, and because it has a $6,350 deductible, meaning that this is employer insurance which will not pay a penny towards medical cost until the worker has absorbed $6,350 in out-of-pocket expenses. So it's basically useless to the vast majority of workers. It is employer coverage, however, and it makes them ineligible for the essential plan. One of the ACS doesn't distinguish, when it asks people about Medicaid, doesn't distinguish between the essential plan and Medicaid in New York. However, the essential plan covers 1.8 million people in the state, probably 1 million in the city, many of them home care workers. Full-time home care workers are probably not eligible for Medicaid. In fact, they're not, but they are almost all eligible for the essential plan. And the essential plan is a very good benefit. Don't want to talk about it. I want to talk about the threat. And there are not many people worrying about this. I think fiscal policy and the legal assistants are the only people thinking about it, trying to get the state to say to PPI, don't do that, because it's going to put the benefits of several 100,000 people in jeopardy. And the state instead has said, isn't it wonderful that this employer is offering coverage? So that's my point about that. I could speak about more if anybody's got any questions. I want to talk a little bit about home care's place in the economy of the city. Home care is the largest single occupation in New York City. And according to the Independent Budget Office, it accounts for home care jobs, account for 3/4 of all job growth in New York in 2024. And this was the case in years as well prior to the pandemic. There was a big drop during the pandemic, but it's jumped right back up, gaining 40 to 50,000 jobs a year in 23 and 24. So it is critical to the economy of communities of low wage workers. I mean, typically there's a one-to-one relationship between a healthcare job and a non-healthcare job, economic job in a community, you know, the grocery store and all the services that communities depend upon, obviously depend upon income coming in to support the local economy. So when you talk about home care, you're talking about an enormous engine of economic activity in many, many low-wage communities, and particularly the Bronx. I think I'll stop there and have other things to say, but I think we need to leave some time for people to ask questions and make comments. I'd be happy to pass it back to you, Max.
That's great. Thank you, Barbara. So on that note, a reminder to everybody participating that you can add any questions that you have for myself, for Vicky, for Max, for Barbara to the Q&A function in Zoom. It should be in the bottom menu bar. One question that's come in so far was a request for any resources to recommend to learn more about worker-owned cooperatives. Barbara, I might send this in your direction first, but anyone else feel free to chime in.
Sure. So the only real cooperative that I know of is Bronx Cooperative Home Care, which is now more than 20 years old, actually. It is a worker-owned cooperative where the workers basically make most of the decisions. They're supported by a very competent professional staff. Home care cooperative workers make more, do more, have more responsibilities than most home care workers. And it's a wonderful model. It took a very, very long time to make it viable. And the state has engaged in a number of activities that have made it less viable. Because as the home care program, the home care program is virtually all sponsored by Medicaid, paid for by Medicaid. It now consumes almost 40% of the state Medicaid budget is spent on home care, which is why it's a target for the governor's budget cutting. It makes sense. On the other hand, they can't trim wages because they're statutorily set by the legislature. So they trim everything else. And they have trimmed trimmed is probably a polite word to say cut everything else. So all of the structures that supported home care workers are gone. The nonprofit agencies which trained them, which certified them, which supported them on the job, which provided assistance. If you're a home care worker on the job and you ran into a problem, you could always call a nurse at the agency and get advice on what to do. Think about the job of a home care worker. Let me just talk about that for a moment. Home care workers are alone with people with some disabled, elderly, and sometimes very sick people. They have the sole responsibility for taking care of that person when they're there, and often they're there for 24 hours. And the whole infrastructure of the nonprofit agencies, which Governor Cuomo basically virtually obliterated with changes in 2015 and 16, means that home care workers are even more isolated than they were before and less supported. And that was all in the name of efficiency. So we have this giant home care system, Medicaid home care system, the sort of supporting the incomes of the largest group of immigrant workers in the city, and also being in some ways abandoned by the state because they have no more supports. I'm circling around back to cooperative home care. So cooperative home care was built to support the workers, and the state has cut off basically all funding for that, making it very, very difficult for cooperative home care to survive. They have, to their credit, found ways to do that around what the state has done, but I worry about their ability to continue to do that as the edges get cut away. That was not a hopeful report on cooperative home care. I mean, you can't have a cooperative without the support of public agencies. And New York has proven to be a very ill-suited partner.
Yeah, I mean, the partnerships and support needed to create a functioning healthcare system are vast, and I think we're seeing the threat of what happens if those partnerships start to erode. Kind of on that front, so Max, you mentioned a little bit about the need for growing the healthcare system, and in particular home care workers, as the city's population ages. I was wondering if you could talk a little bit about DOHMH's work to kind of prepare as much as possible the city and the healthcare system for that demographic shift as people age over the coming years.
Yeah, I mean, we do have a healthy aging program within the office that I work in that focuses on populations with Alzheimer's or related dementias and trying to understand aspects of healthcare needs in that population, and just the population, more broadly quantifying and understanding needs as part of a broader city effort, called the Cabinet for Older New Yorkers. So I think it is a present concern, and a team that's growing to focus on this population in particular from a healthcare access perspective. I think, as it relates in particular to low-income communities, older adult low-income communities, in particular immigrant communities that we focus on. I mean, one major component of this was trying to get the state to a point of expanding Medicaid eligibility for people 65 and over, which has rolled out, gradually over the last 15 months or so since it went into effect in January 2024, and increasing access to eligibility from the consumer side. And I should also recognize that like our team's focus does tend to be more on the consumer side than on the health system or worker side. But I do think one thing that has facilitated through granting eligibility is also, we always want to lift up our partners at New York City Health and Hospitals and federally qualified health centers around the city as, providers of choice and really vital providers for people who don't have a huge amount of choice. But expanding these coverage options also makes it possible for people to be enrolled in plans that then open up access to home health care that they would not otherwise be eligible for. And so from a policy perspective, I think broadening the number of avenues that people have for seeking care, rather than continuing to try to refer an increasingly aging population to a more limited number of services or service providers and access points, is a really important focus area. In terms of increasing the home health workforce, I mean, I think as it relates to immigrant New Yorkers and work authorization, I think this is like a little bit outside of the scope of the health department, but I will say, more broadly, the city has been outspoken, with a lot of things happening over the last several years and people arriving, emphasizing the importance of work authorization and granting work authorization to as many people as possible, as quickly as possible, not necessarily to then direct them into the home health industry. But I do think that ensuring that people have work authorization and that they're able to retain it is a very, very important aspect of this, and a really big threat in the current context where you have a disproportionately immigrant workforce that is being threatened with their ability to continue to work. These things do not align well for an aging city and an aging population.
Yeah, could I add to that last comment? So recent, April 1st was supposedly the end date for all the fiscal intermediaries and the consolidation of the entire paymaster system of the home attendant and personal care program into one single fiscal intermediary. And about 100,000 people were paid on April 8th, which was the first payday. 60,000 people were registered, but because of PPL systems were not paid. And some number, and we don't know exactly, but somewhere between 150 and 200,000 people were not paid, were not registered and not paid. And there's some people speculating, I have no evidence for it, but some people speculating that among the paperwork that the new fiscal intermediary is requiring that was not quite so, documentation was somewhat looser when we had 700 fiscal intermediaries, is an I-9, is a completed I-9, which is an employer, a form for the employer that attests to your legality to work. And there's some speculation in the home care community that many people are worried about either their actual status or their vulnerability if they submit an I-9. So some combination of that is keeping some people from getting paid, which ultimately means some people from leaving their jobs, which has terrible consequences for the people that they would be leaving behind. The patients, the clients who would be left without services, and Lord knows what happens to them. Do they end up in hospitals? Do they end up in nursing homes? Do they end up further weakened by the absence of support? So all of this kind of dovetails together, speaking to the current fear, real and fear and anxiety in a very largely immigrant working population. All I have is dismal thoughts. I'm sorry, Matt.
The world we're in. When we were in the green room earlier, Barbara, you were sharing news on the growth of employment in the city, and specifically in the role that home health and personal care aides play in that. I don't know how much this counts as good news, but I think if you could speak a little bit more to that, we could at least see a little bit more about the kind of importance of this one particular role. There's a reason we keep harping on it, beyond what the report was able to show us.
Sure. If you don't mind, I'll just want to show you a graph from a recent IBO report. It's the New York City Independent Budget Office, which does a report annually on the city's economic status and projections. And this is basically a graph. Can you see it? Does everybody see it? This is a graph which shows it's the larger category. It's the ACS category 62, which is 90% home care. So it's basically home care. The dotted line that goes across here is when the Cuomo administration changed the rules, and which led basically to the destruction of the agency model and the huge growth in consumer-directed care. All those subway ads, take care of your grandmother and we'll pay you, kinship care is actually what's caused this enormous growth. The down piece is the pandemic, but other than the pandemic, the growth has been inexorable, which is part of why New York City's budget costs have gone up so much. New York has a unique eligibility for home care, and I'm just quick to mention this, that in New York State, an elderly disabled person who is in need of home care and has been found so by her physician can receive home care if her income is basically reached Medicaid eligibility standards. And many people are able to reach Medicaid eligibility standards by giving their children or their spouses all their assets. And since there is no look back for home care, in other words, you can have assets of $100,000 on Monday, give it to your child on Tuesday, and be eligible for home care, Medicaid home care in New York on Wednesday. And there has been much discussion over many years of changing that, but that hasn't changed. So it's not that people are cheating, it's that they're using the system to get the services that their elderly aunts and uncles and mothers and fathers need. But it's the growth in the elderly population is inexorable, and so is the demand for home care.
Thank you. No, that I think that goes to show again the importance of this one particular occupation in the full kind of universe of immigrant healthcare workers in New York. We did one more question to briefly address, asking about additional studies looking at specifically the question of home care workers and including voices from home care workers themselves, of course. I can say that this is an avenue of research that we at CMS are planning to pursue in the coming months and years as well. We are putting together details on an event that we hope to announce soon, looking specifically at the role of immigrant workers in home care occupations, hopefully this summer. So please stay tuned to announcements from CMS regarding that, and additional reports and briefs on that topic as well to come. So with that, I think I will go ahead and wrap us up. I want to extend my deep thanks to Max and to Barbara as well for their wonderful comments, and of course to my colleague Vicky, without whom we wouldn't have been able to do any of this report. So thank you all so much for taking time to join us today. It's been a maybe not always uplifting, but an enlightening conversation, and I look forward to hearing from everyone again soon. Take care all.